Hello and welcome to the Answers for Cancers podcast. I am your host, Anne-Marie Fay.
And I'm Michelle Matthews.
Together with some of Ireland's leading experts, we want to unravel what it truly means to have cancer.
From consultant diagnosis to treatment plans, from managing your symptoms to supports available, we have it covered. So whether you're a nurse working in oncology or have been personally affected by cancer, this podcast is for you. We would like to say a special thank you to Pfizer Healthcare Ireland for sponsoring this episode of the podcast.
Today on the podcast, we're joined by the wonderful Dr. Karen Cadieux, who has kindly joined us for a second time on the Answers for Cancers. We first spoke to Karen back in 2022 when she answered questions sent in by the public related to genetics on World Gynecological Oncology Day. Today, she joins us to cover breast cancer genetics. We discuss the benefits and risks of genetic testing, the importance of knowing family history where possible, the BRCA1 and BRCA2 gene, and if somebody carries this gene, what does this mean for them? We also talk about screening and the pros and cons of genetic testing at a young age. Thank you, Karen, for taking the time to speak with us today, and we really hope you enjoyed this episode as much as we did.
Good morning, Karen, and welcome to the podcast. Thank you so much for taking the time to speak to us specifically about breast cancer genetics. You've been so good and have done a recent podcast with us on the ovarian side of things, so it's great to get the chance to talk about the breast genetics. Do you mind just telling me, what is genetic testing?
So thanks very much for having me, and it's really great to be here today and to have this opportunity to talk about this. And I think it's really important for everybody to have more information and awareness about genetic testing. So when we talk about genetic testing, what we're talking about here today really is inherited risk, the potential for inherited risk for cancer. When we talk about genetic testing in cancer, sometimes we're talking about the tumor's genes, or sometimes we're talking about the patient's own genes. And the patient's own genes are those that can be inherited or shared with other family members. And I think that genetic testing is really powerful in terms of providing information for the patient. Sometimes it can explain to them why this might have happened to them, but also help them to understand what other risks they may have and what we can do about that.
Brilliant. And I suppose there's pros and cons to everything. Would you mind just explaining a little bit what the benefits and then some of the risk of undertaking genetic testing?
Yeah, so from my point of view, I always think that information is very powerful. And if you have a mutation or pathogenic variant that increases your risk, of course, it's hard to hear that information. It's upsetting for a patient and their family, but it is powerful in that it gives them the opportunity to do something about it potentially in terms of future cancer risk, but also for some patients, it might be important in treating the cancer that they have. So there's a lot of potential benefit for the patient. And then, of course, for their family members, again, it can be difficult going through the process of genetic testing and finding out that they too may share some increased cancer risk, especially when they've seen what family members have gone through. Yeah. But again, that information can be powerful in terms of modifying their risk and hopefully their future. And that's really the benefit of genetic testing.
Mm-hmm. And then in terms of breast cancer specifically, so can you tell us what percentage of breast cancer occurs because of a pathogenic variant or a gene mutation, as what some people may know it as?
Yeah. So about 10% of breast cancers, if you take all women who are diagnosed with breast cancer, roughly about 10% of them are associated with an inherited risk. So a pathogenic variant that has driven that breast cancer.
And what pathogenic variants are associated in particular with breast cancer?
Yeah, so the genes that we think about in terms of breast cancer risk, I think what people would be most familiar with are BRCA1 and 2.
Yeah.
So they've got a high risk of breast cancer associated with them. PALB2 also has a reasonably high risk, quite similar to BRCA. And then genes that we sort of understand more about more recently, CHEK2 and ATM, are the ones that we would think of most commonly. There are some other genes involved as well that we potentially test for, some that may have more ovarian cancer risk, but may be implicated in breast cancer, RAD51C and D, not so much BRIP1. They're the main genes that we think about. There are some other rare variants. P53 is associated with a very high risk of breast cancer, unfortunately, and young breast cancer, but it's very rare. Yeah. And some other rare variants like P10 and STK11 that are not very commonly seen, but they're the main things that we think about.
It's interesting hearing all of those, because I always just commonly associate BRCA1 and BRCA2. Yeah. You know,
and BRCA1 and 2 are relatively common in comparison to something like P53, and we do have more awareness of them. And you know, I think it's important for people to have awareness of the potential for genetic risk in general, and the specific genes may not be so important unless you're actually in this space, and you know, then we can give people more information. Yeah,
it's really encouraging to see that there's obviously a huge amount of research, because all of these new genes are being identified, which is only helpful for people. In terms of the criteria that a person has to meet to deem them eligible for genetic testing, do you mind telling us a little bit about that, and if there's specific guidelines that are followed?
Yes. So yes, there are guidelines, and yes, there are criteria. And in breast cancer, they are a little complex. So it can depend on the person themselves or their family history, or both. So for example, if someone has a breast cancer diagnosis personally, their age of diagnosis is important. So independent of their family history, if they're diagnosed under the age of 45, they'd be eligible for genetic testing currently, and that has changed. That's the other thing to be aware, that the criteria have changed over time, and they have changed quite recently. It also depends a little on the type of breast cancer they have. So for example, if someone has a triple negative breast cancer, they're eligible for genetic testing up to the age of 60, regardless of their family history. And the reason for that is we know that for women who have a triple negative breast cancer, they're more likely than women who have an estrogen receptor positive breast cancer to have a BRCA pathogenic variant. And then in terms of other criteria, for example, if someone was a little older, for example, a 50-something-year-old with an estrogen receptor positive breast cancer, then we'd be looking to the family history. So additional relatives with breast, ovarian, pancreas, and sometimes prostate cancer. And it depends on what the cancers are, how closely related the people are, and the number of cancers. And so this is where it can be a little bit hard for people to follow the criteria. The other thing then we think about is people, what we would say, who are unaffected with cancer. So somebody who has a family history of cancer but does not have a personal diagnosis themselves. Most people who are unaffected with cancer do not meet criteria for genetic testing. And in fact, until recently, we weren't in a position to do genetic testing at all for people who didn't have a cancer diagnosis personally. Part of the reason for that is it's always better to test the person who has the cancer, because the testing of the person who has the cancer is more informative. However, we do recognize that's not always possible in terms of living relatives, for example. And so we use criteria now, a thing called CanRisk. It's a risk assessment algorithm. And if somebody is unaffected and does not have a living affected relative who's appropriate to test, then if they meet a certain risk score on the CanRisk algorithm, they may be eligible for genetic testing on that basis.
That's really, I suppose, reassuring for people. It could be quite fearful knowing that there's a lot of people around you, but you're not affected yourself. But there's still, I suppose, a risk assessment there for them to feel like they're being watched in some kind of capacity.
Yeah, and so the CanRisk algorithm is very useful because it provides a couple of pieces of information. One is what their chance of having a pathogenic variant is, and we use that information to determine eligibility for genetic testing, but it also can give us a lifetime risk of their lifetime risk of breast cancer, for example, and we can use that information to determine whether or not screening might be appropriate for them, or I should say enhanced screening might be appropriate for them. So even if they're not eligible for genetic testing, they may be eligible for enhanced surveillance, for example, additional breast cancer screening, not just the sort of national screening program or breast check. So it does provide that information, and CanRisk is a very good algorithm based on a lot of data, which also includes some personal and lifestyle risk factors, not just your family history. And that's very important information in terms of playing into the risk assessment as well.
And if somebody is sitting at home now and they're listening to the podcast and they have a huge family history, but there's nobody that's eligible for testing, the first step for them to go about that risk assessment, would that be for them to go to their GP?
Yeah. So the GP can refer them in. It's really important that they provide as much information as possible, and as clear and accurate information as possible. And then that helps us to do a risk assessment.
Brilliant. And then in terms of, so if somebody is actually deemed eligible then for genetic testing, and they've been referred in, like practically what does that look like for a person?
So it depends a little bit on the situation, but in general, what happens is the patient has some kind of a preliminary assessment where we might ask for additional family history information, usually through a family history questionnaire. And then they meet with a genetic counsellor or a genetic nurse specialist. That's usually by phone, actually, or video call. And then in terms of the actual genetic testing itself, it can be done either through a blood test or through a saliva test. So what we can do is mail a saliva kit to somebody's home where they can do the testing themselves, and then the kit can be sent back. And then in terms of the results, they can either get that again by phone, or we are moving to hopefully more video conferencing, and then in person is an option too. But just to be clear to people, we are a national referral service here at St. James's Hospital, but we don't necessarily require people to come here personally. Occasionally, the mailing of the saliva kit and returning it can take some time. So if we're in a little bit of a hurry, sometimes we do ask people to come in or to go to their own provider, for example, their oncologist or GP for a blood test. But in general, we are able to provide a service that can be remote for people if that is what works for them.
Brilliant.
I suppose it's one positive that came out of COVID, isn't it?
Yes.
That people actually trust the kind of remote monitoring and remote service and that kind of stuff. Whereas before it might have seemed a bit like, oh God, it's a video call. We're just so used to it.
And I think the video calls are fantastic. The phone calls, it's harder for us to tell if people are sort of understanding the information without the body language piece of it. And so we really are trying to move more to the video call piece. A piece that I didn't mention before though, and I think probably is worth mentioning, is there's now what's called direct order genetic testing for some people. And when you asked me about eligibility for genetic testing, what I didn't mention is that for some people, for their own personal cancer diagnosis, I did say earlier that it can be important for their treatment. So for some patients who have a breast cancer diagnosis, if the genetic information is important for their treatment, their oncologist can send what's this direct order genetic testing. So that means they have a conversation with their oncology team, they send off genetic testing, and then they give them the result. If they have a BRCA1 or 2 pathogenic variant or uncertain variant identified, then they come to genetics for more information and counselling. That direct order genetic testing, though, is for BRCA1 and 2 only. It doesn't include those other genes that I mentioned. So sometimes people could have that direct order genetic testing, and if it's negative, they still might need additional genetic testing. So just good for people to be aware of that slightly different pathway as well.
Yeah, no, it's really clear. I think it'd be really helpful for people just to visualize how it works. And I think what I'm picking up from what you're saying is that actually them spending a little bit of time and actually really evaluating the history and getting as much information before they come can really help the process along.
Yes, absolutely.
Brilliant. And then I suppose if there is a BRCA1 and BRCA2 pathogenic variant identified, what is the percentage risk of developing breast cancer over a person's lifetime? And then what are their options for reducing this risk?
Yeah. So unfortunately, if you have a BRCA pathogenic variant identified, the risk is reasonably high. We quote about a 60 to 70% lifetime risk of breast cancer. And just to give people some context, the general population risk of breast cancer is about 12.5%. So it's about 5 times the general population risk. We are learning more about this, and just to sort of give people, I suppose this is really more for the future, but trying to understand not all BRCA pathogenic variants are the same. So while we quote this kind of high risk right now, in the future, hopefully we'll be able to drill down better for individual patients what that truly means for them. The thing that I always think about as well is not just your lifetime risk, which unfortunately is high, and that's a difficult thing to think about, but also what's your short versus medium term risk. And sometimes depending on the family history, and sometimes we can use the CAN-RISK algorithm again to help us understand what people's risk in the next 5 years versus 10 years versus longer is. So obviously for young women, some of that risk is much further away than for some of our older patients. In terms of reducing this risk, I suppose there's 2 things that we think about. One is enhanced surveillance versus risk reducing surgery. So enhanced surveillance means doing MRIs in addition to mammograms, and doing mammograms obviously starting earlier and with increased frequency versus, for example, the National Screening Programme. With enhanced surveillance, the chance of you getting a breast cancer diagnosis doesn't go down, but the chance of us picking up breast cancer at an earlier stage, for which you would need potentially less therapy and more curative breast cancer, is much higher. And so that's a good option for lots of women. For some women, the prospect of having a breast cancer at all, of course, is not something that they is for them, and so doing risk reducing surgery is the option they choose. And of course these things change over time. For very young women, for example, we may be recommending doing surveillance initially. For example, they may be family planning, and then at another point in their life, then risk reducing surgery might be the answer for them too. So it depends a little bit on where people are in their life as well.
It's great to know that that's considered. It's such a huge thing, like you said, family planning and stuff for people. And I can only imagine if you're told that you have a BRCA mutation and the risk is quite high, there's so much to consider. So it's great to know that really heavy surveillance is an option. And that these people are really well looked after.
And I think that piece as well about the short versus medium versus long-term risk is important as well for younger women. That sometimes that whole lifetime risk, of course, is very scary. And for some women, to be fair, their short-term risk, they can get a young breast cancer. But, for many women, it's the lifetime risk that we're worried about, but their short-term risk may not be as high. Yeah. And so, it's trying to educate and understand about that as well, because, obviously this can be very difficult for women who are young, lots of things going on in their lives, and, taking this information in, but trying to stratify when they need to worry about it too.
Yeah. And you mentioned there about the screening them a little bit more regularly. What does that look like, and how often would somebody be screened?
Yeah, so there is they usually go to a high risk screening program with often, for example, in a breast surgery service, and they do start MRIs usually from 30. Sometimes we start a little bit earlier depending on the family history, and additional mammograms, and then it depends a little bit on the family history and the screening service. But they would have annual mammograms as opposed to, for example, breast check, which starts at 50 and is less frequent.
And can I just check, because I know we're mentioning women in this a lot.
Yes.
For men,
yes.
Like, is that kind of similar?
Yes. So for men, for BRCA2 in particular, they do have a risk of breast cancer. It is much lower than it is for women. They have about a 6% lifetime risk, but of course that's much higher than the general population is for men. For men, we don't necessarily recommend surveillance if they have breast tissue or gynecomastia, because we do recommend that they do chest exams and have vigilance, and of course it's important to have awareness for themselves and their GP. Sometimes men do mammograms if they have tissue to image, but that's a more individualized pathway, I suppose.
Perfect. And then what are the chances, I suppose, then of somebody passing on the pathogenic variant to their children?
Yes. So obviously that's one of the things people worry about a lot. So I just want to highlight, of course, their children, but also their siblings need to be thought about, and the wider family, depending on if we know which side of the family it's coming from, cousins and all the rest. So there's a 50% chance per child that they will also inherit the same pathogenic variant.
And is there psychological support offered to people in this instance within the genetic testing kind of?
Yeah, so part of the genetic counselling process is to provide some psychosocial support, not just information. So genetic counselling is a term that's perhaps not very well understood by a lot of people, and as a profession it's not as well established or recognised in Ireland as it is elsewhere. The kind of primary roles of the genetic counsellor. So when someone comes to, you were asking me about genetic testing, and so I didn't explain this bit. So when they meet with a genetic counsellor who explains to them about information about genetics and inheritance, what the potential outcomes of the test will be, what the test looks like, and then of course if they have a pathogenic variant identified, what that means for them and for other family members. And they do provide some psychological support. I will say in this country, again, this is something that is not as well established or recognised as it could be. With
it doesn't seem to be just part and parcel. It's
right. So the genetic counsellors do provide some support. However, the additional psychological support, but from a psychologist, for example, is not very widely available, and I think is very important. So when I worked in America, for example, we did have a psychologist embedded with a genetic service, and that's something that we do not have here, but would like to have. I think, however, there's been a lot of progress recently, both with the National Strategy for Genetics and Genomics, and the NCCP is developing a hereditary risk strategy that will be launched soon. And I think within that, we will hopefully have some more opportunities for greater psychological support for patients.
That's great to hear. And I know that obviously there's not a huge amount we can do to change people's genetics, but in terms of lifestyle change, is there anything people can do to help increase or reduce the risk? I suppose?
Absolutely. So this we don't know very well, and actually we're doing some research in this, but the lifestyle risk factors that exist for people in general presumably also apply to people who have a pathogenic variant, for example in BRCA. So how much that adds to their risk, I don't know for sure, but that's what's part of what we're looking at. I totally agree with you. We cannot change their genes. If we have information about them, we have that power to change things like screening, but also to be mindful of our behaviors. So a healthy diet and exercise, for example, moderate in alcohol intake, all the things that we would recommend in life. Interestingly, a researcher here in St. James's, Dr. Sarah McGarrigle, did some research with patients who had BRCA pathogenic variants a few years ago, and she found that a huge proportion of those patients were overweight or obese, which does increase your breast cancer risk. And virtually none of them were meeting the recommended exercise guidelines in terms of minutes per week. And so I think it's really important that people think about the things that they have control or power over in their lives, right? And to be very mindful of these pieces. And I did mention earlier about that CAN-RISK algorithm when we're looking at breast cancer risk assessment. Those factors like alcohol intake and body mass index are part of that risk assessment because they're important.
That's brilliant. Yeah.
So I suppose just to discuss reproductive options then. So we know that the BRCA1 and BRCA2 also increase the risk of ovarian cancer. So if a pathogenic variant is identified in a woman of childbearing age, what are the reproductive options that are available to them?
Yeah, so this is really important, and this is a space that is changing, I think, quite rapidly. So a few things we think about. So first of all, in terms of family planning. So as you said, they have a risk of ovarian cancer, and unfortunately, there is no screening available for ovarian cancer. And currently our only option in terms of reducing risk is risk reducing surgery. So we encourage women to have their families early if possible. Of course, that's not always feasible in life. And for women in general, we recommend risk reducing surgery between the ages of 35 and 40 for BRCA1 and 40 to 45 for BRCA2. And it does depend a little bit on family history. For some women, the recommendation may be younger. If a mutation is identified, the other thing that, or pathogenic variant as we now call them, the other thing we think about for some women is, and it's a very personal choice for a family, they do choose to do IVF and select embryos where they know then that their children are not going to share this pathogenic variant. And this is something that is done somewhat commonly in the United States, depending on the situation. As I said, it's a very personal choice for people and their families, and it does involve full IVF with the emotional and financial costs of that. And similar to the United States, that is done in the private setting. Here it's not done in a publicly funded way currently that I'm aware of. But as I said, that is something that may be available to people if they choose. For people who are in this situation, I think that speaking to their GP even, and having some advanced thoughts about their family planning and what they would like to do, I think is really important. And there is more information and there are more options in this space than there were previously.
And then if there's a pathogenic variant identified within a family, is there a minimum age recommendation for genetic testing? And I suppose if there is, what are the pros and cons if there's no cancer identified at that point?
Yes. So if we stick with, so the age partly depends on what gene we're talking about, and what age we would initiate some risk reducing measures, either screening or surgery. So BRCA1 and 2 is really what we're talking about here today. So in general, we would say for women roughly around the age of 25. And that's really because we start thinking about breast cancer screening. As I said, we'd start MRIs potentially at 30, and sometimes a little younger for some patients depending on their family history. And that's really why we kind of pick that age. People can do genetic testing earlier than that, but you know, this is very challenging information for some people and very stressful. And if you're at a point in your life where you have a lot going on, you're trying to make decisions about where you're going in life, it can be challenging to take this additional information on.
That's overwhelming.
It can be overwhelming and stuff, exactly. The one thing I have to acknowledge, though, is that our current wait list in the public service is relatively long. It's approximately 2 years, unfortunately. And so from that perspective, when I get referrals for very young people, I do triage them to an appointment, knowing that, you know, if they're referred at 18, which is really too young, I would say, to do genetic testing for BRCA, depending on the person and their level of maturity and what's going on with them. But it doesn't mean we couldn't have a conversation about it. But I also am aware that if our wait list is 2 years, then they're going to be 20 by the time they get that appointment. And so I just triage them to an appointment at this stage, and then have that conversation when they're 20, and they might not be ready then, and that's okay too. So I think, you know, it is a tough balance sometimes for parents and for their children. You know, they want this information, but they may be seeking reassurance of a negative test, and we have to be very careful that they're really thinking through what it might feel like to have positive test results. And the terminology we use in genetics is actually very challenging, right? Because a positive test result in life, positive things are good, but we're talking about an identification of a pathogenic variant that increases their cancer risk. And that's a huge thing to take on board. So there's no perfect age for people, but in general 25 for women. For men, although, as we said, when we think about BRCA, we think breast ovarian cancer mainly for women, but there are risks for men too. Male breast cancer, although usually older, they don't tend to have such young risk as women. And then other things like, for example, pancreas and prostate cancer, again, especially with BRCA2, but again, usually not so young. So for men, they may have more flexibility about the timing of testing, and some people want that information younger, and some people, if they don't want to do that testing till they're a bit older, probably not going to make a huge difference to them. The only arena where it may make a difference for men is if they did think it would have implications for their family planning. Again, that's a very personal decision, and for many men and families that may be less of a consideration than for women who have a BRCA pathogenic variant, but sometimes for men, depending on what their partner's family history looks like and what other things are going on, that may play into their decision making as well.
I suppose the most important thing I'm picking up from you, that it sounds like it's a really individualized kind of care plan for each person. So it's something that they really have to consider their own individual wants and needs, and have a discussion with a healthcare provider to make the best decision for them. And I totally agree with you, and I do want to kind of just stress the point that if someone's 18, are they making their own decisions, or is the family part of that? And just to be, and I understand that parents are anxious, but obviously people who are 18 are adults, but at the same time, the emotional maturity can vary, and how much they're able to take on board. And it does vary a lot depending on what else is going on in their lives at that age, right? Brilliant. I think we've covered an awful lot. I suppose, is there anything you think we might have missed out on that's important to mention?
No, I think the couple of things that are important, I think we've really highlighted. One is that even if you're not eligible for genetic testing, you may be eligible for enhanced surveillance depending on your personal family risks. I think it's very important to stress about men too, so it's good that you brought that up. And I think what's also important, and the men piece plays into this a little bit, is to test the right person in the family. It's really much more informative. It's not just about resources and whether or not we want to test somebody. It's really about what's the most informative thing to do in terms of understanding risk for a given individual and or other family members. And sometimes the man can be a linker to the rest of the family, and older Irish men in general are often less open to engaging with medical professionals and genetic testing. And so I would strongly encourage people to encourage their family members who have been advised to have genetic testing to proceed with that, even if they're not interested from their own perspective. If they would do it for other people in the family, I think is really valuable, and it can really help inform risk more accurately for people.
It's really good advice. That's great. Thank you. Sounds like a really exciting area to be in, and it seems like there's always more coming every time we talk to you. So listen, thanks so much for your time again. It's always a pleasure.
Thanks for listening to the Answers for Cancers podcast. Please share this podcast with anybody who you think it might help. Also, if you can like and subscribe, it lets people know we're here. You can alternatively contact us on Instagram at the